MHC-TV is here to help explain and demystify a variety of health issues and treatments with leading doctors in the field who practice right here and are available to you. And because we know how important diet and exercise are to good health, we are also featuring segments on easy and fun solutions to get you and your loved ones moving. You'll also be coming to my house, where I'll be cooking up some of my favorite recipes to show you how simple, tasty, and satisfying healthy cooking can be. MHC-TV is about education so that you can make healthy choices for a healthy life. There's many different patient groups that we take care of. For instance, pediatrics. We do have a pediatric division here in Middletown, and at the same time, Monmouth Medical Center has a very large pediatric group with multiple subspecialties. It's one of the largest deliveries of newborns in the state, and we run an excellent pediatric program. When we move up to young adults who usually feel invincible, but we have walk-ins where young adults may come in with minor problems such as sprains or upper respiratory infections. And then once we treat them, we may find that they have other issues such as diabetes or high cholesterol, and we can then get them access into our system and to whatever specialties they need. Lastly, we have a very large population of elderly patients and Medicare patients, and that's at least 50% of our practice. And they require many different subspecialties. And once they are accessed into our office, not only will they come for usual visits, but if they have urgent visits, they can come to many of our different offices as we have walk-ins. We can direct them to our subspecialists, whether it's a cardiologist, urologist, surgeon. The concept of medical health centers has always been there to take care of its community. By giving easy access and easy diagnostic testing and easy care to these patients, we've developed a great relationship with our community. Now with Barnabas Health Group, we have a broader network of resources, and we can take care of not only local problems, but if the problems become quite significant, we now can transfer to many of our different facilities where they can get the care that they need. Hello, today we're here with Dr. Susan Hudome, who runs our neonatal intensive care unit and is a neonatologist. I know, Susan, it's a highly specialized field. Besides college, 4 years of medical school, 3 years of pediatrics, you probably put in at least another 3 years in the intensive care unit.
That's correct.
And it's interesting, the word infant in Latin comes from the word infans, which means unable to speak. Which makes it quite tough when you're a doctor. And I know these infants have special needs and significant problems that you deal with. So why don't you tell us a little bit about what a neonatologist does and about your team here at Monmouth Medical Center?
Well, as a neonatologist, we take care of babies in the immediate newborn period out to about a month of age who require specialized care because of a large variety of problems.
And I'm sure the parents are quite anxious having a child in a neonatal unit. And why don't you tell us what a parent can expect when their child is there? Because I, believe it or not, had 2 premature children. And I remember having to wash my hands every time I walked in. So what can a parent expect?
So we start with making everyone take off their jewelry, scrub for at least 2 minutes, and then, of course, use the alcohol-based soaps every time they touch something else besides the baby when they go back in to touch the baby again. Our staff follows all of those regulations as well. The other thing I think most parents notice, for better or for worse, when they come is that we don't allow a tremendous volume of people to come with them. They are allowed to bring visitors, but usually we try to limit that to 1 or 2 other people at a time.
Tell us a little about the isolette.
It's a pretty sophisticated piece of equipment. It looks like a lucite box, but that device actually has temperature modes that can regulate the baby's temperature and the heat output from the device so that it tests the baby and then puts out the correct amount of heat to keep the baby in the proper range. Premature babies don't tend to regulate their temperature that well initially. Their brains are not really meant to do that yet, and they should be still inside the mother. So the incubator kind of helps to monitor and regulate their temperature so that they don't become stressed by having to keep themselves warm. When they have to do that without an incubator, they may burn more calories and not grow properly, and so it's a very important piece of what we do.
And I've seen the kids right there. Some of them are on ventilators. They have all these lines put in. Believe it or not, before I went into internal medicine and cardiology, I was in family practice. And I did a 3-month P's rotation, and guess where I did it? In a neonatal ICU, because I was good with lines. So I don't envy you. I mean, that was a stressful area to work in.
And of course, parents always want to hold their babies, our smallest babies, because they'll get cold if they're held. Sometimes we have to wait a little bit of time until they're a little bit more stable, but we do a lot of kangaroo care. And I think the mothers and fathers both find that to be very helpful. So that is a skin-to-skin holding process where the parent will put the baby right against their chest, and we kind of tuck them in so that the body heat from the parent keeps the baby warm. So they're then able to hold these children at a much smaller age and size than they would otherwise normally be able to do. Really, the babies love it, the parents love it, it helps with lactation. It's really a nice bonding time for the parents who unfortunately sometimes feel that they can't be as involved as they want right away. I think that's the hardest thing for a mother here, is that they're separated from their infant. They can't hold them and feed them and take care of them in the way that they had hoped to do right after delivery. Our nurses are absolutely wonderful about involving our parents and helping the mothers to learn how to take care of their babies, even if it's simple things like doing the kangaroo care or holding the tube for the gavage feeding, or helping, to change the bedding at night and be part of weighing the baby and things like that. So, it's a process that our parents go through. And it really is a whole team approach in terms of what we do and how we monitor things.
I just think even of the nutrition. I mean, you have a preemie that's, let's say, less than 32 weeks, or their sucking reflex isn't there, and even if they are giving their mother's breast milk, that probably the nutrition isn't enough to support these kids.
It's not, and initially they don't gain weight as well as if they were still in utero, but we do like to get feeding started as early as possible. Just having even a little bit of breast milk helps the bowel to continue to grow and develop and get better at absorbing the calories later. And it also reduces some of the risks for infection, so the immunologic benefits are tremendous. Developmentally, we know that it helps them a lot as well in terms of brain growth and nutrition. So we really focus a lot on trying to get our moms involved, pumping early, getting a milk supply established. We have a donor breast milk program as well, so if mom's milk supply is lacking a little bit in terms of quantity, we can supplement that if necessary with some donated milk. We're trying to really limit formula exposure in these very tiniest of babies at least until they're older and their immune system and GI tract are a little more able to tolerate other proteins.
I'm sure you run into problems with meningitis or sepsis, infections, and unfortunately, baby can't tell you I have a stiff neck, or the fevers are going up. How do you make these diagnoses, and what do you do?
Well, there's a lot of signs that they give us, even though they can't speak to us. We watch their vital signs. They may have a faster heart rate. They may have more apnea spells. They may have temperature instability. They don't often run a fever like an older person, but they may be a little colder or need a little more heat output from the incubator. They may have subtle changes in their blood gases or their blood counts, the white cell counts and platelet counts. So we kind of look at a whole lot of information and put it all together. And it's really very important to have continuity so that we have nursing staff and doctors who know the baby and can say, this baby looks a little different today. Sometimes we have our mothers come in and say, my baby doesn't look the same today, something's going on. And we try to pay close attention to that because oftentimes they're right, there is something going on. So we try to gather all the information we can from the people that know the babies best. That's their bedside caregivers, and that helps us a lot to try to put together the puzzle pieces, whether they're infected or not infected. But we do a lot of looking for infection. Fortunately, we in general have very low infection rates, but we're always monitoring that. We keep scrubbing. We belong to a national database from Oxford, so we track all of our outcomes and complications and infection rates so we can benchmark against other units and make sure that we're really doing the best job that we can in all these areas. You know, I think one of the best features of our unit is that it really feels like a family-centered place, and yet you don't have to go to New York or Philadelphia to get the same level of support and care, you know, for your baby, and the parents can stay local with their families. A lot of times there's other siblings at home and things like that. It's amazing how a baby at 24, 25 weeks and even a day old can tell you their likes and dislikes and position themselves or respond differently to one caregiver than another. They definitely know their parents' voices. It's good for them to have that positive reinforcement. We have to stick them and do things to them, and we always encourage the parents to, you know, even leave a little tape in there with their voices, reading a story, pictures to help stimulate their visual development. But they definitely have their ways of letting us know, you know, whether they want their diaper changed or they don't want their diaper changed. Or,
let me tell you, that,
you know, it's amazing.
You're
really
in a tough field. I remember I was good with lines, so I would do the arterial sticks. I would do the scalp veins. I would do the umbilical cannulations. And like after a few months of that, I said, there's no way I'll do this the rest of my life. It's tough, it's tough.
Well, it is tough. I think every area of medicine has its, you know, its hard and easier parts. You get comfortable with what you do. So, you know, for us, some of the things that are so scary for parents are everyday things for us. The baby has an apnea, we're like, oh, you know, for them it's, you know, it's very scary. So we have to kind of talk them through those things.
It
a
is
lot
scary.
of it is counseling and teaching.
I think mine, you know, was on a ventilator for a day or two. And like I said, my God, my kid's on a ventilator. Are you kidding? But yeah, all in all, you get through it. And if you can support the family, because yeah, at least we're in a medical field. Yeah. But if you're not in a medical field, this has got to be so frightening when you come to a NICU.
It can really be overwhelming for many of the moms, and it takes time. They have to work through the process of learning about the unit, getting to know the people, getting to know their own baby, and
getting information.
Yeah. Although we do really try to, you know, to keep in very close contact with them and talk to them frequently. Sometimes if it can't be the attending talking to them, our nurse practitioner, one of our residents and nursing staff, we tell parents to call anytime they want to check on the baby. It doesn't matter what time of day or night it is. Call, ask the questions. Sometimes even just personalities. The four attendings may say things in a slightly different way, and a parent says, "Oh, I didn't really hear it that way from the other person." So we say, "Please, you know, let us know," because we're usually on the same page, you know, but it may be phrased a little differently. So don't hesitate to, you know, to talk to people.
Sometimes parents hear what they want to hear.
Well, and sometimes they're very stressed and they only hear a small part of what you said. So we kind of, especially when the mothers first come in, we kind of expect that we're going to have to go over this a couple of times, that we're going to give them a whole lot of information initially, and they're going to only be able to process a certain amount, and everyone's different in that amount.
So Susan, you had to develop a team approach here. Who's part of your team?
We have a large amount of people that work here, and the parents get to know all of us very well. We have 4 neonatologists, we have hospitalists, we have nurse practitioners who assist us in providing care to the babies. We are also a teaching institution, so we have residents that rotate through our unit, and we have a large group of staff nurses who are very expert in taking care of these babies. Some of our nurses have been here for many, many years. I think we're talking up around 35 years. Some of the older ones have been here. We always have a certain amount of turnover, but we really have a lot of people that stay and enjoy working in this area. And we try to utilize their talents to teach the new people the ropes.
And I'm sure some of these parents have special needs, and social workers probably help them
with that. We have a social worker. We also have physical therapists that come up and assess the babies as they get older, to help them with perhaps positioning and stretching and things like that, so they don't become stiff or limited in how they can move around in the incubator. So a lot of, and we also have at our disposal the Children's Hospital resources. So we use subspecialists frequently for our patients. We might use pulmonary, pediatric surgery, cardiology, radiology. So we utilize all of the other subspecialties to help us. We really have pretty much everything available here. So we send a few babies out to other hospitals when we can't continue to give them the care here.
Having had 2 preemies, actually in this NICU, I can tell the parents that they grow like weeds, and before you know it, But you seem to have a well-rounded program. Is there anything else you'd like to tell us about the program?
I think there's so many components. We're always trying to improve and expand. Right now we're growing. We're trying to renovate and expand our unit to accommodate more families. We're adding some space for parents to be able to stay overnight and learn some of the baby's care as they go home. Some of our smallest kids who are here for a very long time, really it's almost a transition home rather than a discharge. They have to learn a lot of things, how to use nasal cannula, oxygen, monitors, medications. So it's nice if the parents can kind of do that in a supervised setting before they're home without the nursing staff that's been supporting them for all this time. It's a complex area to work in, but I think the key is good communication and having so many people at different levels working together to provide the best care for them. We really try to take care of them like they're our own children and you know, give that personal component to the families as well.
I'm sure you have scores and scores of pictures.
We do. Christmas time, we get all the cards with the, and every September, one of our nurses several years ago started a fundraising walkathon. So the families often like to participate in that and come back, and it's kind of like a little reunion. They can, you know, bring their children when they're discharged and older and running around and healthy. Babies are incredibly resilient, so even some of our children who have been so sick can really do very well down the line and turn into normal, running around 2-year-olds. So.
Well, Susan, thank you very much for keeping the community and the families connected to good health.
Oh, you're welcome.
Good afternoon. We're here today with my good friend Art, a young tennis player at the age of 81. Art, what do you attribute your longevity to?
I attribute it to good living. I eat a lot of fruits and vegetables, and I drink very little alcohol.
Do you do a lot of stretching before you play?
I do a little stretching in the morning, and that will hold me the rest of the day.
Is it true that you're still teaching tennis?
Yes. I only teach 7 to 8 hours a day, 5 days a week.
So,
And I play the rest of the time.
can others follow in your footsteps?
Yes. If a person does not want to run, they can walk. And you can start with a few hundred yards a day and work up to 5 or 10 miles. I myself walk 5 miles a day. I don't want to tell my walk. I was in New York the other day, I walked 10 miles.
One of the simplest and most important things you can do is to remember that before you even open your mouth to order, think about portion control. So let's get into the kitchen and show you more about what I mean. So, as you can see, this is a nice piece of lamb, and whenever I always wash the lamb off, it's been washed already, but whenever I buy fish or chicken or meat, I always wash it off, and then I try to trim off any extra fat. And obviously there's a nice layer of fat here. Cutting away from yourself, I try to just take off as much fat as I can. A little bit healthier. As you can see, this part of the meat here still has some fibers. So what I do is I just make little incisions. So this way it's going to hold better whatever liquid I put on and whatever spices I put on. So what I'm going to do is just put lemon over the whole piece of meat. And now that is going to be able to hold my spices. So garlic always goes good with lamb. And I have the garlic, salt, parsley mixture. And what I'll do is just pour it over, because once I do this, I'm going to bring it out to the grill and I'm going to sear it. By searing it, it's going to keep all the flavors inside, and then we're going to bake it. And now I have some pepper that I'm going to put on this side. And again, I'm a big parsley person, so we will add some parsley to that. Now that this is ready, wash my hands. And I'm going to take this out to the grill. It'll take about less than 5 minutes to sear it before we put it in the oven. So here's the lamb that we already have seasoned. And what I'm going to do is put it right on the sear, and we'll let that cook. And while I was inside, I took some of the asparagus, just with a little bit of olive oil and my salt and pepper seasoning, and we're going to grill them for a few minutes. So place it right on the grill. As you can see, the lamb is being seared on the backside, and it's very hot. You almost can't stand here after a few minutes. And once that's seared on one side, all I do is turn it over. We will turn it over and sear it on the other. In the meanwhile, rotate my asparagus. So our asparagus is done. And as you can see, we have a nice crust on that lamb. And now we're going back inside. Ready, Gus? Let's go. Now that we have our lamb nicely seared, I'm going to coat it with a combination of Worcestershire sauce, A1 sauce, a little bit of soy sauce. I had some cilantro from my garden. I chopped it up and placed it in there because lamb and cilantro, when I lived in Mexico for a while, was a great combination, and particularly those tacos al pastor. And then remember, different parts of your tongue can taste different substances: sweet, sour, salty. So what I've added to that was maple syrup. And I put some maple syrup in it. You can add honey if you like, but just a little maple syrup. That helps in several ways. Number one, it helps make it a little thicker and it sticks on the meat better. So what I do is this is this combination. And basically what I'm gonna do is just put it on, make sure I coat all parts of the meat. And then I will even put it on the opposite side. I have my pan, and remember the little trick, just so that it doesn't get too hot in there, and have a little steam, and it's ready for the oven. Now I'm going to cook this for a little while, and then I'm going to come back and put the pistachio crust on it. But first, let this cook in the oven for about 15 minutes. All right, so now, how to make the pistachio crust? Well, we have some of that sauce left over. That sauce goes back into a bowl, and we need the pistachio nuts. So here are some pistachio nuts, and I have a very scientific way of crushing them. I place them in a little bag, plastic bag, and then I get my towel so I don't crack the granite, and I find something hard, and I crush it. And that's what you do. Now, you can crush it very fine, or you can have some, leave them a little thicker, which I prefer, so that you get some more granulation and you get more texture. And this is the mixture that we're going to use for the last 15 minutes of cooking. Now, lastly, we made some asparagus, and now I'm going to make some broccoli with some brown rice. So, once again, I will heat up a pan with extra virgin olive oil, because that's what the Italians use. And I will spice it up with a little garlic, salt, and parsley, my broccoli. And we will then saute this. This is not going to take long, and you'll see the green color of the broccoli will start really coming out. It actually gets greener as you're sauteing it. Now remember, we're going to need some liquid for the rice, so I will add my chicken stock. Turn down the flame. Give it one more stir. Now, if you wanted to, if you like the broccoli al dente, remember, a little harder, and you're done. If not, let it cook a little more. And I have my brown rice here. Again, there's so many convenient ways to buy food today, and it's so easy to cook. You don't have to go through all the headaches. The brown rice gets dumped right in. Remember, that's why you wanted the liquid, so you can incorporate it with the rice. And we'll let this settle for about 2 or 3 minutes. And that's how easy that is to do. Now we're up to the part to put some of the pistachio nuts and end up crusting the lamb. As you can see, there's a nice, beautiful color on it. I will take my sauce with my pistachio nuts. And I told you, we even put a little maple syrup in there, but you can use honey, sweet, salty, sour from the lemons. And once it's all coated, back in the oven, about 10-15 minutes. Maybe if you like a nice crust, the last minute or two, put it on broil, so you get a nice little crust over it, and you'll be done. And basically, that's the meal. Pistachio crusted lamb with rice, broccoli, and asparagus. A portion of this would be 2 or 3 lamb chops, some rice and asparagus, and that will be well under 600 calories. A little red wine, though, would help. Now let's taste it. We're gonna cut this piece into little pieces. I always get the first piece. That's pretty good too. But we have to have our taster's taste. How's that? Oh, you gotta chew it. And we gotta give Skylar a piece. We can't let her watch. Remember, part of living healthy is also having fun. Have fun.